Well, I would like to thank everybody who's attending our momentum sessions here at the Gerontological Society of America. We have a great discussion that is awaiting us on obesity in older adults and its effect on the increased risk due to COVID and other health conditions. We have experts in the field of geriatrics and gerontology that will provide us great insights into this topic, and you will have handouts with their biographies and some suggested references that will be helpful from that you may be able to read either before or after the session. The program will last roughly 60 minutes. It'll be a question and answers by our panelists. I'll be moderating the discussion and open the discussion at the end to audience members. I also want to thank our supporters and our Novo Nordisk for their contribution to allow this session to occur. By way of introduction, my name is John Batsis. I'm a physician researcher at the University of North Carolina at Chapel Hill and a faculty member in the Gillings School of Global Public Health at UNC. And what I would like to do is introduce our panelists. Shen Dewar is a geriatrician and certified in obesity medicine from the University of Michigan. And Ted Kyle is a registered pharmacist and a leader in ConscienHealth. And Kathryn Starr is a PhD registered dietitian from the Duke University School of Medicine. Each of our panelists will provide us differing insights, I think hopefully exciting insights from their perspectives on this important topic and manifestations as a result of COVID as well. So without further ado, I would like to jump right in and maybe ask our panelists to turn their video on. Super. Well, let's jump right in, all, and welcome to the GSA Momentum session. Really excited to be here with you this for the session. I think before we start off, I think a big question that a number of our audience members, both our gerontologists and geriatricians alike, will have are maybe we can kind of provide some background on what the current definition of obesity is in older adults. Shen, maybe you can start off by, defining obesity and how we define it in older adults.
Yes, John, thank you. So we define obesity in general in clinical practice based on BMI, which is weight in kg by height in meter square, which puts a BMI of 30 to 34.9 as class 1 obesity and 35 to 39.9 as class 2, and more than 40 as class 3. But a better reflective measure in older adults is something which could reflect the metabolic health, which is waist circumference, which is more than 40 in men and more than 35 in women is considered high risk. And that is a better reflector of obesity as the body fat gets redistributed as one ages.
That's great. And, and how does obesity impact one's function? Because we think about excess adiposity, changes in body composition. How does it affect individuals' everyday life? And thinking about the pre-COVID area, because obviously things have changed in terms of everyday living during COVID.
That's right. So both aging and obesity are associated with the poor muscle mass and function as the adiposity, which leads to lipid accumulation between and within the muscles, lowering the quality and the muscle generation, which is myogenesis. Now, obese individuals are also in general less physically active even before COVID, and hence they also develop some degree of muscle dystrophy or disuse atrophy, what we call. Due to all these above reasons, obesity impacts mobility and functional status, affecting quality of life, predisposing them to false injuries and likelihood of institutionalization. Studies in older adults have shown that it also negatively impacts social and mental well-being, leading to lower health-related quality of life for both men and women, and also involves in the role limitations, health perceptions, bodily pain, energy, fatigue, and impaired social functioning.
Great. So why do we think that obesity is different in older adults? Maybe Katie, I don't know if you, as a registered dietitian, I'm sure, in part of your clinical practice and research, you see this, but how do you think, how is it different, say, than your younger population?
Yeah, absolutely. So I think in regards to the differences with obesity in older adults is really what we've already been speaking about is really that functional component and that loss of function and that impact on abilities to get around and quality of life and independence. Obviously, we know that in younger populations, function can be impaired by excess adiposity. However, we see it at a much exaggerated state in our older adults. And I think the other component here too is also with the physiological and metabolic changes that are happening with aging in combination with obesity, we see an even, a greater impact on the intermuscular adipose tissue, the ability of the muscle to actually work properly. And so you now have these two different issues going on, not only what's happening as we get older, but adding into that adiposity, really impacting just our quality of life, function, and then, obviously the independence factor here for our older adults. And obviously this is really pre-COVID as we're thinking about that as well. And so I think really kind of differentiating between our younger and older populations, you have to consider those physiological and metabolic changes that are occurring along with this extra adiposity that now these individuals are having to deal with.
Great. And Ted, from a practical standpoint in terms of care providers, how do patients see themselves who are, diagnosed with obesity or classified as having obesity?
Well, I think it's safe to say that as I think all of us so far have alluded, the medical complications of obesity tend to accumulate over time. And so as you start talking to, as patients or people living with obesity reach a more mature state, they start to confront the reality of the impact of a lifetime of obesity because it is a chronic disease. However, it's important to recognize that obesity is a highly stigmatized condition. And so even at an older age, although less so than younger patients, people are not comfortable with that label obesity. Mm-hmm. Because, for instance, there are lots of providers out there that would never call someone diabetic or cancer-ridden, that will refer to someone who's living with obesity as obese, as if that is their entire identity. And that becomes very uncomfortable for the person. However, as people age, they are less able to avoid the medical consequences of obesity. They tend to accumulate.
Great. And when we think about the rates of obesity, they obviously have changed over the last number of decades, which is certainly impacting everything from, clinicians and providers viewing, managing their health conditions, and we'll come back to that. But also in terms of thinking about malnutrition and frailty, which of course is, as gerontologists and geriatricians, we worry about that is the ultimate end result if in this process. Katie, can you share a little bit about the interplay between obesity and frailty?
Yeah, absolutely. And I think I first just want to say I appreciate what Ted has said. And I think for many providers, we have gotten used to saying obese older adults, and we're going to have to teach ourselves and really relearn how to not utilize that terminology. And I think it is something that, in regards to the stigma, something we really need to practice as providers as we move forward, because I think he makes an excellent point about that in regards, especially in younger and our older adult populations. Moving to the prevalence of obesity, as we definitely have seen this elevation. We have now reached the 40% mark for both men and women who have a BMI of 30 or more, for individuals who are 60 and older. I mean, that is monumental when we start thinking about this combination of the global graying with this obesity epidemic and what's actually happening to our patients. And I think many of us have a vision of, when we say frail, malnourished individual, is more of a kyphotic, very skinny, small individual. Whereas we really do have to change our lens and understand that the obese individual who has obesity, who has excess adiposity, can also be malnourished. And it's kind of this double burden, just along with functional limitations and aging and having excess adiposity. So is this understanding of malnutrition. And just because someone has what we would call a lot of times excess reserve does not mean that they are immune to being malnourished. And it is really important to make sure that we are aware of addressing that nutritional status, understanding that nutritional status, and screening for these individuals. Because oftentimes many people say, oh, we categorize people as being malnourished based off of a BMI and say, oh, they're fine, they're clear, they're good, without starting to think about what is their functional status. Because going along with that idea of malnutrition and frailty, we have this, again, double whammy here of this individual who may have extra adiposity, very low lean muscle mass, and their ability to move around, get around, is going to be impaired. So, I think as we're seeing this increase in obesity in our older adult population, we have to start thinking about how the nutritional status is going to be changed, how we define frailty, how we define malnutrition, because it's no longer just that small, slow gait individual. It can also be someone who has extra adiposity and also unable to have ambulation outside of their household or ambulation at all. So very important to really think about and change that frame.
So it sounds as though that, in addition to all the medical challenges and the incident, challenges with quality of life, functional status, we really need to be thinking about screening and food security in this population as well. And is this something that, from a clinical standpoint, is done routinely in, say, a primary care setting? Or is this something that we should be advocating from a policy standpoint?
So I would definitely say both of these things need to be done. I think that we need to really be tackling this on both ends of the front. And, the screening for nutritional status is not routinely done in our primary care facilities. I mean, it's not older adults come in with a number of comorbidities, and we have limited amount of time with them. And a lot of times the nutritional piece might be put on the back burner unless it's very evident. And so again, kind of understanding that need to be assessing for nutritional status across all BMIs is extremely important. And in regards to the policy components, I think we've made some headway, but we are nowhere near where we need to be in really assessing for nutritional status, particularly in our patients who are probably being forgotten about, to be honest.
And Ted, I don't know if you have any thoughts from the policy standpoint, from a healthcare system standpoint, that you may be willing to share.
Well, absolutely. One of the consequences of weight bias is that we have this cultural view of obesity, that it is a health behavior and not a health condition. In fact, even the AHA has this outdated definition of obesity as one of the 7 healthy habits that you can establish. Well, now, obviously, BMI is not a healthy habit. It is a physical reality, okay? But culturally, we cling to that idea that obesity is purely a behavior, and it's not. But when you operate, or when the health systems come at it through that lens, when payers and health plans come at it from that lens, it can make it very difficult to obtain reimbursement for a patient who has obesity for nutritional services, because that will get screened and kicked out, because routine exclusions for the treatment of obesity, regardless of any medical necessity, are present in many, many health plans more often than not.
Great. So maybe we can change slightly directions here and really kind of take the next steps, is thinking about the pandemic that we are faced with, COVID-19. How are people with obesity, patients with obesity, really responding to this pandemic? How is it affecting individuals with weight issues and who are struggling, and particularly older adults with weight issues? Maybe Ted, do you want to maybe provide some perspective?
Well, I guess what I would say is that obesity is something that, as all of us have alluded, really affects people's psychological health in a profound way, absent the pandemic. But in the presence of the pandemic, and in particular with all of the attention that has been paid to obesity as a risk factor for severe outcomes, this has created some severe problems for people living with obesity. First of all, there's a lot of anxiety, and so people are tending to avoid routine care, which creates further problems and actually life-threatening situations for people when they really need that care. There's extreme anxiety about exposure to the virus, and that really is what you might, in some people, even refer to as a paralyzing fear. And there's also anxiety about the effects of restrictions that result from the pandemic on normal activities, and what effect that might have on diet and exercise, and the possibility for weight gain, and the fear that weight gain will put them further at risk. So all of that adds up to a situation where there's a lot of anxiety and not a lot of empowerment to do something to deal with that anxiety.
And we'll come back to the challenges with weight change during the pandemic. But maybe, Shen, can you maybe share some of your clinical experiences within, the geriatric care setting of challenges with regard to managing individuals, older adults with obesity from a health promotion standpoint during the pandemic? I don't know if you can just share some of your insights.
Yes, for sure. Yeah. So, as Ted pointed out, obese patients are fearful even coming to the clinic to get their care. So, and if they are economically up there, they are able to tap the resources and do a video visit. And I had been successful providing those in my weight management clinic to those. But there are a few who live in the low socioeconomic status who are not able to tap the resource and are fearful to come in. And we also need to know that they have high cardiovascular risk. So if they are caught with a chest pain or severe headache, they are very much worried to go to the ER, and they tend to postpone their early warning signals. So this ending up in the ER with a much more higher complications. But I have to say that I have been overall successful in providing care virtually, just because weight management is a lot based on behavioral approach and making sure they sustain their lifestyle changes, which in itself has some hardships in the pandemic, not able to go to the gym and so forth. But there is a subset of patients who are very challenging, whereas a good handful of patients we are still able to provide care.
With regard to COVID-19, are patients with obesity at higher risk? And while the data is probably still emerging, what do we think about older adults with obesity, since we know age is a markedly a risk factor for critical illness in the pandemic?
Sure, I can answer the question. So the exact mechanism, as you said, John, is responsible for the COVID-19 complication remains unknown in obesity. However, based on the insights from other viral infections like influenza and some epidemiological evidence, there is some understanding that obesity increases the severity of COVID-19. As often you know, obesity is associated with a lot of conditions like hypertension, type 2 diabetes, kidney disease, and liver disease. All of these increase the risk of COVID-19 infection. Also, low vitamin D is highly prevalent in obesity, which is considered a risk factor for COVID too. And ACE2 receptor is a major binding receptor for COVID, and the level of its expression in adipose tissue is higher than in the lung tissue. And hence, adipose tissue can act as a reservoir for COVID-19, and so it's obesity. Also, the physical features of an obese individual could likely increase COVID-19 risk and severity. The impaired lung, the mechanics, the sleep apnea association, and the respiratory dysfunction increases the risk of the hypoventilation, pneumonia, pulmonary hypertension, the cardiac stress. It also, obesity impairs the diaphragmatic and chest wall movements also, and it also gets complicated with mechanical ventilation. So this is the inflammatory explanation. Obesity induces the chronic adiposity inflammation and hence high concentrations of the pro-inflammatory cytokines and adipokines. And the metabolic dysfunction in the obesity leads to lower anti-inflammatory adipokines like adiponectin. So there's a dysregulated immune response in obese patients, placing them at higher risk for complications.
And maybe I could kind of ask Katie her thoughts from a vitamin D standpoint and nutritional standpoint. Is there literature on vitamin D in COVID and vitamin D in obesity in older adults that we should be thinking about, or research questions that we should be asking and evaluating while we're in this pandemic?
Yeah, I think that's an excellent question. And, so I think one of the things that we have to kind of really think about is, for many of our older adults, they've been socially isolated or tried to be socially isolated. They may not be getting out. They may not be purchasing their own groceries. They may not be in control of the food that they're getting in, nor the activity that they're getting in. And so when we kind of think about, I like, the big picture here, and thinking about even with vitamin D, understanding the likelihood of them having low vitamin D status is pretty high, which I think we all know, and many physicians are now testing and really trying to supplement when there is a deficiency. But if we're having our older adults not coming into their PCP on a normal basis, that could be a huge problem. And so, for most individuals, they're not going to be able to get their vitamin D through their diet. And a vitamin D supplement is usually the best way to handle that, along with a calcium supplement if they're not able to get that through their diet. And so the first recommendation would be to make sure that they are getting in 1,000 IUs of vitamin D per day. And if that's not even possible, we would want to, do our very best to supplement that with a vitamin. In regards to questions about research for COVID-19, I mean, I think that we do have a wonderful opportunity to look to see what is actually happening in regards to vitamin D status and COVID prevalence, particularly for our older adults who are living with obesity. And are we seeing anything different with these individuals? Or are there ways that we may be able to intervene and try utilizing vitamin D vitamin D supplementation to try to mitigate some of the impacts that we're talking about here, particularly for our older adults who do live with obesity. And we know that the other component here is that if they're undergoing, weight loss, or anything like that, we know that that's going to also have an impact. And really important to make sure that they're getting in their vitamin D status, at least 1,000 IUs, and maintaining really a blood level of 30 or more nanograms per milliliter. And if that's not being achieved, they're going to be at risk. And so I think the bottom line is, this would be a time in which we really do want to add a supplement if they're not already on a supplement, because the likelihood of their vitamin D status to be deficient is probably pretty high, especially if they are isolating and really not moving around as much and not getting in the food that they're used to getting in. If they're trying to get that through the diet, which most people cannot. It's a very challenging thing to get enough vitamin D through your diet. So we do usually try to have them supplement with that.
And this is really helpful. And one of the things that we've heard in the media is the COVID-19 15 or the quarantine 15. What are your thoughts on that? Ted, I don't know if you've had a chance to, if your experiences with, with staff, or, from a health promotion standpoint, in older adults, what are your thoughts in terms of how we can advise our patients or advise individuals to mitigate that? Or the other way you can look at it is, what evidence do we need, or what interventions should we be thinking about advising or studying to prevent this from happening?
So a couple things I'll mention, since you raised the issue of press, one relating to what Katie was just talking about. There has been intense interest and attention given to vitamin D. I have been rather shocked when I write things about vitamin D, just how intense the interest is, because I see people flowing into my website every day. And I think when I wrote something about vitamin D, it hit an all-time record that day. That's how intense the interest is. And there are folks out there in the consumer media who want to position vitamin D as some sort of panacea, a miracle. And it's worthwhile keep thinking into account, not at 1,000 units a day, but at higher doses, there is the possibility of getting too much vitamin D. But it is important to give that sensible message that Katie was giving, that says, you know what, you just don't want to be deficient, and let's pay attention to this and be sensible about it. So that's one thing. Then the COVID-15, akin to the freshman 15, that is really a pretty noxious meme that serves mainly to increase the anxiety of people in an already overwhelmingly anxious time. Better to encourage people to practice a little bit of self-compassion, and and help people find a healthy pattern for life during these unusual times. And that healthy pattern for life involves also managing your stress and managing the patterns of things that are preying on you in this unusual time.
And I appreciate you sharing that, because we see that terminology in lay press. I've seen it in scientific articles, and I think there needs to be it sounds like from what I'm hearing here, there needs to be kind of a reframing of that terminology, of that issue, and really recognizing the challenges within COVID-19 and how we can surmount some of those challenges using various strategies.
Rebecca Pearl from the University of Pennsylvania published a very useful overview on the harmful aspects of that COVID-15 terminology, and so that's worth taking a look at.
That's great, and I think we can certainly have that as a reference for our audience, following our discussion. One element that is certainly worries, and we've talked about the challenges of older adults coming into the clinical environment, and particularly those with who have are classified as having obesity are at higher risk of certainly COVID complications. Individuals who need surgery are certainly older adults, are at higher risk perioperatively, but now with COVID, they may be at higher risk, and particularly those who are at risk or who have obesity or classified as having obesity are at higher risk. What should we be telling our patients who are thinking about elective surgery and are thinking about, should I come to the healthcare center? Should I not come to the healthcare center for an elective procedure? And it would be curious to hear, each of you have different perspectives from a clinician, from obesity clinician, from a dietitian perspective, and from a health systems perspective. I would be really curious to hear what your perspectives are. What do you say about these elective procedures? Not chronic care, but elective procedures.
I can go. So as a clinician, I faced this challenge definitely earlier on in the peak of the pandemic, March, April, May, when the advice was, if it's an elective procedure which can wait and they are not impaired by it significantly, they were allowed to wait. But as the pandemic evolved, it could vary in geographic regions. So waiting for even non-extremely painful conditions could turn into a very acute condition later on. So as well, we had advocated them to proceed on with the surgery when the peak of the pandemic had subsided, at least in Michigan for us. That's kind of the advice we had told. This comes with bariatric surgery also in older adults. There is a debate of whether we need to recommend bariatric surgery for those waiting because of the fearfulness of acquiring the COVID-19 infection. So overall, elective surgeries can wait when there's a peak of the pandemic, whereas a non-peak, they can go ahead with the surgery.
Yeah, and I think from the nutrition perspective, and working with older adults who are preparing for surgery, it's a tricky situation because just as was already mentioned, some of these situations, even a hernia, could very quickly turn into an emergent surgery. And so navigating that, and also understanding that this pandemic has lasted a lot longer, I think, than many of our patients thought it was going to, and now they're at a place where they're like, I can't wait anymore, or I don't want to wait anymore. Or, even if we're dealing with our patients who have cancer, it's still considered an elective surgery, but it's more of an urgent situation. These are the individuals where what is the hardest part about this now is the fact that they don't have their care providers with them at their bedside. And I think that's been the hardest thing for, me to be able to, I rely on these care providers to help with their nutrition, to help with their dietary intake, to help be an advocate when maybe their mother or their father isn't acting like they normally do, to alert our team to say something. That's what we do. We really do rely on these individuals. And now that we don't have them by the bedside, I actually think our older individuals are really going to be impacted by this. This is going to have long-term impacts for these individuals. And I think in regards to surgery and having excess adiposity, many times we hear surgeons say, you need to lose weight before we can have this surgery. We need to get you to lose some weight. However, a lot of times they're not being told how to lose that weight. And so for some of them, and for some of those individuals, they end up really taking in 800, 900 calories a day to lose weight so that they can have a surgery. And that's a really big red flag for me, because even though they're saying it's intentional weight loss, that's really kind of getting into this starvation mode because we're losing muscle mass. So kind of even in this COVID area and not in the COVID epidemic, surgery for our older adults who may be, have a higher BMI, have a higher waist circumference, we do need to be mindful of how we're instructing them to prepare for surgery. I always say that this is not really the time for weight loss. Unless it has to be. And if that's the case, then surgery should be postponed. But it's really time for changing the dietary, the composition of the diet, really working on making sure that we're focusing on our higher quality proteins, our fruits and vegetables. I always say, like, this is our small window of time where I'm going to ask you to really eat as healthy as you can, and as, be as focused on this as possible, because it's going to help you get to that goal that you want, which is surgery, and hopefully it's improving that quality of life and independence. So surgery is a very tricky place in COVID and outside of COVID, especially with our older adults who may be battling or dealing with having extra adiposity.
And I would like to just add that the decision for bariatric surgery in an older adult is very much an individual calculation, where some older adults can be very, very good candidates for bariatric surgery, and some really don't stand to benefit from bariatric surgery. And so that's a decision that needs to be made very carefully on a patient-to-patient basis. But what I would say is, when you have an older adult who is really indicated for bariatric surgery and can benefit and understands those benefits and is eager to see that, it's worth thinking about the importance of the control of chronic conditions that surgery might help with, and thinking about that as something to take into consideration as you decide when then to schedule that surgery. I know, for instance, the American Diabetes Association says, when they talk about the risk of diabetes and severe COVID outcomes, that the real risk comes with uncontrolled diabetes. And so if you have a patient for whom control of diabetes might best be achieved through bariatric surgery, then that's something you want to give careful consideration to.
So what I'm hearing here is that carefully selected, individualized patients who may be placed at higher risk because of their other comorbidities should still consider, say, bariatric surgery as a modality for treatment for obesity, but really needs to be individualized and weighing risks and benefits thereof of the comorbidities in this time, this pandemic time. Is that a fair summary?
I think it is fair summary. Yeah, excellent.
Great.
Yeah.
Well,
the other thing that this conversation brought up, that's kind of on a different tangent, is the importance of dealing with obesity as a chronic condition in this setting, because a lot of what Katie was saying about managing nutritional status, historically we thought about, what is obesity treatment? Well, it's helping people lose weight. But for these patients that we're talking about, no, it's about maximizing their health. And you can only maximize their health if you're really looking at that condition as a chronic disease that creates unique clinical needs, unique nutritional needs.
and I think Katie brought up a really important point about diet quality as a important driver of health behavior change and nutritional behavioral change. That's an important key step. I would like just to get your perspectives of, I've had colleagues, geriatrics colleagues, who have suggested, is it more about the weight loss? Is it more about the physical function? Is it about both? I would love to hear your thoughts on that.
I'll start with that one. I'm a strong believer of both, utilizing both of these modalities, and it's not about big changes. And I think that that's one of the big issues that we deal with, is people think that they're, I think not just individuals, but as a society, we think that we have to make all of these huge changes to get these these benefits. And really it's small changes. It's going from not exercising or not walking to walking. It's going from, if you're having a very difficult time just getting out of a chair, practice getting up out of the chair and sitting back down. It's not having to go run a marathon. And I know that that's a bit of an extreme here, but what I really do try to emphasize is that it's focusing on small changes that are something that can be achieved. And every time we hit that achievement, it means that we're one step closer to where we want to be and what we want to do. And I love what Ted said, is that if we think about it as a chronic health condition, we do change the way that we practice care and provide care. Because really, I mean, I try to focus on what is happening to our muscles, and when you talk to someone who can tell that their muscle mass has gone down, they're not able to do the activities that they used to be able to do, it really resonates with them. And then we start talking about, okay, so what can we do to try to help build that muscle back up? And then it's like, oh, okay, this is something I can relate to. I can work on these things. It's not, you gotta lose this amount of weight and you gotta do this and you gotta do that. It's, how do we put the positive spin back into this so that we can get back to that level of independence? And for some individuals who are unable to move around because of the weight, we do need to move. We need to start very slow, and we may not be able to see as much gain, but we can utilize the diet, utilizing protein intake, higher quality protein to try to help preserve that muscle while they're slowly, gradually losing weight. But really, it's changing the diet. It's making very small changes a little at a time until we can get a grasp on this and really start making big gains. So that's kind of my approach, at least.
Well, maybe we can, one of the things that was mentioned earlier was the importance of a loved one in one's management in the older adult with obesity. And so I'm coming out to the topic of social support, which is so important in older adults. How has COVID-19 impacted social support for our older adults, and in particularly those who maybe who have challenges in their function because of obesity?
Well, I'll say it up front that it's worth considering the possibility that social support for a person living with obesity is not always going to be a positive thing. It is not uncommon for family members to actually sabotage someone who is dealing with a weight issue or a weight problem. And so it's really important to take a realistic view of that. Now, that's independent of COVID. COVID, of course, introduces significant challenges because people are experiencing significant social isolation.
And how about like homebound individuals? I don't know if you've had any experiences, either Shen or Katie, in terms of the homebound individual with regard to their nutritional status, in either they live alone or they're in a skilled nursing facility or assisted living facility.
Yeah, this has been a really difficult time. And I would even say, there was a moment where, even moving into kind of the congregate meal program and our Older Americans Act nutrition program, where it was actually halted until they were able to figure out, okay, how are we actually going to handle this? And they were still providing meals, but the way the Older Americans Act nutrition program is designed is certain amount of money goes to congregate meal programs and certain amount of money goes to home delivered programs. And so there was a bill that was passed, which is great, that allowed the distribution of money to be moved very freely from congregate to home delivered meals, so that those needs could be met. So that is one thing where, we've there's been movement on that front. However, I think even for the average older adult who may not be as tech savvy, getting groceries was a challenge. Now, when we add the homebound individual, there is a level of difficulties with getting access to food and getting adequate food. And I know that the food insecurity rates have definitely gone up dramatically. And I don't even know if we've actually been able to capture that fully. But I have a very high suspicion that when we do our annual evaluation of the prevalence of food insecurity in our older adult population, we are going to see it jump from 8% up to a higher level, just because of the fact that, you know, these individuals really have suffered from not being able to access food. And if they don't know how to get access to these resources, you know, that's the other area, that's the other problem. And I have found that a number of our providers are not necessarily aware of these programs to even recommend them. I know our social workers definitely are, but again, if we're working in silos, you know, I think this has brought a very important message to us as healthcare providers, is that we really do have to understand what resources are out there for our patients, because we may be like, especially if we're doing a telehealth, being able to say or ask and making sure that these individuals have food, have access to food, are able to prepare food, you know, again, because food insecurity is not necessarily being able to buy food, it's also being able to get it and cook it. And if they can't do that, that's still food insecurity. And again, I think with the COVID-19, the fear of going out, all of that has impacted the risk for food insecurity and having access to food.
And I think you raised a great point, you know, about involving individuals as part of the interprofessional team. And I would love to hear Shen's point of view as, you know, when you as part of an involvement, as part of an interprofessional team, how has the interprofessional team stepped up to our older adults with obesity?
So, I mean, I can describe this in various settings. So in outpatient primary care setting, the interprofessional team was able to do these as part of telehealth visits because of a lot of counseling involved from the nutritionist aspect of it. But when it comes to physical therapy and rehab, there had been a big gap because it is close contact. So there is a divide. Some disciplines were able to pick that up and go much more faster than disciplines where you need more contact with the patients, which is changing now.
Mm-hmm.
When we go to subacute rehab and assisted living facilities, COVID or pre-COVID, it's not great for care of obese older adults with respect to nutrition. They've not stepped up to take care of the nutritional needs of obese patients. They still get their baggage of cookies every day and the orange juices in long-term care or assisted living. So I think there is a big gap, which I think policy-wise needs to bring a big change. More so in COVID, they are unable to go to the dining room, even walk up and get the fresh hot meal. They are served in packed cold food, which is not palatable, and they merely walk. So I think COVID situation has worsened in other facilities, other assisted living and subacute care facilities.
So this has been a great conversation. So before we open our discussion to questions from our audience, and again, I want to ask a very closed-ended, targeted question to each of our panelists here, and I'll ask you to keep your responses to about 15 to 20 seconds. In the era of COVID, what do you feel is the largest unmet need for older adults with obesity? Shen.
The unmet need for obese older adults is accessing care is number one. Unable to go and get the diagnostic studies which they need due to the fear of stepping into a healthcare facility is a major problem, which I feel. I order a polysomnogram, I order a 2D echo to assess their cardiac function. They are not able to go because of the fear. So that's one thing I feel as a clinician, I face a challenge.
Katie?
I would say the one unmet need is being able to connect our older adults to each other. Particularly, I think a lot of the social engagement and the support system and the accountability for people, for older adults who were living with obesity, it may not be there anymore, especially in regards to having other individuals who are doing the same thing they're trying to do, if eating healthy, exercising, and without that access to even the gyms or that social interaction and that level of stress that Ted mentioned. I feel like they're really missing out, and it's probably having a big impact.
And Ted.
Access to high quality, ongoing care that treats them as a whole person and meets their whole needs for health.
Well, this has been a great discussion. Again, I want to thank all of our panelists for their time, and to our supporter, Novo Nordisk, on behalf of the Gerontological Society of America. Again, want to ensure our audience is aware that we have handouts, key references, and citations from some of the information that we, as panelists in the field, are important to our audience, and we'll open to questions. Well, thank you very much, everybody. And I'm going to dive into some of the questions here. Shen, we've discussed understanding what obesity is, the importance of understanding what is appropriate nutrition and exercise, and the importance of addressing stigma to help older adults with obesity. Under what circumstances might there be a role for medications, and what is available for older adults in practice?
So most of us are aware that weight regain, otherwise called the weight cycling, happens in almost 80% of patients with lifestyle modifications. Bariatric surgery, on the other hand, is the only treatment option which yields sustainable long-term weight loss, but has challenges in older adults. So medications do play a role as they fall between the lifestyle intervention and the surgery by helping to overcome the physiological counter-regulatory mechanism, which is the cycling phenomenon, which is behind the cycling phenomena. But the safety and the efficacy data on older adults are limited because they are done under 70 years, and hence we have some knowledge gaps. Hence, clinicians need to adopt a very patient-centered approach, carefully checking off the contraindications led to absolute comorbid conditions in the polypharmacy. There are a few FDA-approved medications like liraglutide, orlistat, phentermine, topiramate, and bupropion, naltrexone approved. But these options do exist to older adults, but one need to take consideration of the comorbid conditions, as I said, like a patient with uncontrolled diabetes and high risk for CAD will benefit from liraglutide. Likewise, glaucoma and headache limits other medication like bupropion, naltrexone. Hence, the choice gets very limited. But one more simple strategy and effective is switching patients from weight gain medicines to weight loss medicines. Actually simpler, can be done in a primary care setting, like switching insulin to metformin. Insulin is an obesogenic medication, whereas metformin is a weight loss medicine.
That's great. Thank you very much, Shen. A question from our audience here had to do from the Nurses' Health study, which attempts to answer the fat versus fit phenomenon. And maybe I can address this to Ted. The findings from this analysis suggest that improving physical activity, even modest improvements, conferred greater improvements in all-cause mortality and morbidity compared to reducing obesity per se. Can you comment on this fat versus fit phenomenon?
Absolutely. One of the things that is important to bear in mind is that in general, obesity care guidelines are moving towards emphasizing health first before weight. Canadian guidelines for obesity care just came out this past summer, which made that very point. And so that observation from the Nurses' Health study makes all the sense in the world. It's not that weight is irrelevant, but it is that health comes first. And there are many things that you can do in addition to managing weight to optimize the health of people who are living with obesity. And if you lose sight of that, then really you can compromise a patient's health.
That's great. Thank you very much. What barriers do you see in older adults that face access to obesity treatment if funding were not an issue? And maybe Ted, you can springboard onto that question.
So I guess what I would say is that for older adults, the approach to obesity care is a little bit irrational because of Medicare. Medicare pays for surgery, which can be very beneficial for carefully selected patients, as we've talked about it. But Medicare also restricts access to other evidence-based care, like, for example, dietary interventions by a dietitian. In fact, dietary interventions are only paid for by Medicare under the care of a primary care physician. And primary care physicians don't do dietary interventions. So as a result, it just doesn't happen very often, all because of the nuts and bolts of how it works. Same thing for pharmacotherapy. And here I'll speak from personal experience. I'm getting ready to go on Medicare. I've been taking an anti-obesity med for some time to take my weight below the mark of obesity and maintain it at that lower level. Well, I can't find a Medicare Advantage plan that will pay for my medication. So there I am faced with probably paying out of pocket, which can be quite expensive.
Got it. Another question from the audience is testosterone therapy treatment is becoming more frequent. Is this beneficial only up to a certain age for men in the reduction or slowing of lean muscle mass and atrophy? And perhaps we can kind of attack that from two perspectives, the clinical and from the research perspective, because there's data in what we do in clinical practice and what is some of the evidence in clinical trial data.
I think we can start with clinical practice. Testosterone in a geriatric population itself, the use is pretty limited. And when it comes to older adults with obesity, they do have intrinsic high-risk cardiac disease. So I think testosterone in clinical practice needs to be approached with extreme caution after screening the obese patients for cardiovascular risk factor, their risk scores, and the intent of the need. So I think I feel that there is extreme limitation in use of testosterone in obese older adults.
Great. Katie, maybe are you able to kind of comment on the impact of testosterone on, say, body composition in older adults?
Yeah, so as we get older, we do see that reduction in hormonal, our hormones, estrogen and testosterone starts to decline. And so with that, we see a reduction of that lean muscle mass. And so again, it's important to remember the metabolic changes that are going to happen with our older adults, and the implications, which that means is that we're going to see a loss of lean. It leads to that loss of lean muscle mass. And, in combination with, as we've already said, in combination with excess adiposity, it's going to have a big impact on our function, the ability to move around, and the ability to even meet some of these guidelines, these exercise and physical activity guidelines, if we're having excess adiposity in combination with low lean mass. So it is important to remember that and keep that in mind.
Great, thank you. Another question from our audience is, do the functional impairments associated with obesity amongst older adults depend on which diagnostic criteria has been used to classify the condition? For instance, body mass index derived versus DEXA derived fat mass versus potentially waist circumference and the like.
Yeah, so there was a recent study actually that was done by Kim and colleagues in 2017 that actually looked at body composition, BMI, and also percent of body fat. And what was interesting is that they actually both found that there's association with slower walking speed and lower short physical performance battery. And there was another study that was done, I think around 2008, that actually showed that a BMI of 35 or more was associated with slower and less efficient gait speed. So I think that the nice thing here is that for most of us, we don't have the ability to, have a DEXA and look at percent body fat all the time. And so it's nice to know that even that BMI marker is a good indicator for physical function and decline in physical function.
Great. Well, we have less than a minute to go here, and certainly really want to thank our audience that attended our session, and importantly, panelists here for a really great and lively discussion. And certainly to our audience, we have the references that should be available online for you. So I want to thank you on behalf of GSA and Novo Nordisk that has sponsored this GSA Momentum session as well. Thank you.